Hello everybody, good day to you all. My today's presentation is on wound care management. Let's begin with the anatomy, structure and function. It is the largest organ of the body. Its primary function is protection. It is composed of several layers. The outermost layer, epidermis, dermis containing the capillary, subcutaneous layer containing the hypodermis, adipose layers. Its thickness varies from a thin membrane at an internal flexure, for example the elbow, to the thicker at the sole of the feet, which bears considerable pressure. Hair follicles, sebaceous glands, and sweat glands pass through the epidermis but arise from the dermal layer. What is the definition? A wound can be defined as a cut or a break in the continuity of any tissue caused by an injury or an operation. Wounds can be classified according to their nature. Abrasion, a contusion, incision, could be a laceration, open wounds, penetrating wound, puncture, septic, etc. Classifying wounds. Wounds may be classified according to the number of skin layers involved. The superficial layer, partial thickness, and full thickness. Superficial layer involves only the epidermis, while the partial thickness involves the epidermis and the dermis. Full thickness involves the epidermis, dermis, fat, fascia, and even exposes the bone. So the wound healing, what happens in wound healing? Wound healing, the body repairs damaged tissue, and it is divided into two, acute wounds and chronic wounds. Acute wound heals quickly within days and weeks, whereas the chronic wound heals slowly, wherein it takes even months. Acute wound is any surgical wound that heals by primary intention, or any traumatic or surgical wound that heals by secondary intention. An acute wound is expected to progress through the phase of a normal healing, resulting in the closure of the wound. Whereas in chronic wound, a wound that fails to progress healing or respond to the treatment like any other normal expected healing time frame, which is the 4 weeks, and it gets stuck to the inflammatory phase. This pathological inflammation is due to a postponed or incomplete or uncoordinated healing process. Wound healing is delayed by the presence of intrinsic and extrinsic factors, including medications, poor nutrition, could be comorbidities, or inappropriate dressing selection. The ways in which wound heals, three basic classification exist. First is healing by primary intention. Second, healing by secondary intention, and then delayed primary healing. Now, what happens in healing by primary intention? Two opposed surface of a clean incised wound, which no significant degrees of tissue loss are held together, and healing takes place from the internal layer outwards. Whereas in the secondary intention, if there is a significant tissue loss in the formation of the wound, healing will begin by the production of granulation tissue from the wound base and the walls. And delayed primary healing is if there is any high infection risk. Patient is given antibiotic and closure is delayed even further for few days. It could be a insect bite, for example. Tissue repairs and regeneration involves three phases. First is the inflammation phase, the reconstruction phase, and the maturation phase. Now, the inflammation phase consists of 0 to 4 days. The body's normal response to injury. This phase activates vasodilation, leading to increased blood flow, causing heat, redness, pain, swelling, and loss of function. And wound exudate may be present. And this is also a normal body response to a wound. Whereas in a reconstruction phase, it takes from 2 to 24 days. The time when the wound is healing, the body makes new blood vessels which cover the surface of the wound. This phase includes reconstruction and epithelialization. The wound will become smaller as it heals. Now, what happens in epithelialization is the epithelial cell moves upward and repairs the wound areas. So, the most important process is in the wound healing. Then the maturation phase. The maturation phase takes place from 24 days to 1 year. The final phase of healing, when scarce tissue is formed. The wound is still at risk and should be protected when possible. Now, moist wound healing. Basic concept is that the presence of the normal exudate will provide an environment that stimulates healing. Exudates contains lysosomal enzymes, WBC, lipokines, growth factors, which are essential for the healing. There are clinical studies which have shown that wounds maintained in a moist environment have lower infection rate and they heal more quickly. The factors affecting healing. The factors that affect healing are immune status, blood glucose level, where impaired white cell functions. Hydration causes slow metabolism. Nutrition, blood albumin, oxygen, and vascular supply. Pain and corticosteroids. These all factors depress the immune function. Wound assessment. Now, wound assessment is done when we do wound assessment, we consider the size, the depth, and the location of a wound. It considers the skin, the color, and the moisture of the surrounding area of the skin. The wound bed, whether there is necrosis or granulation is taking place. Then sometimes lab test to find out signs of infections, culture test, odor, exudate, the smell of the wound exudate, and the wound edges. These all should be taken into consideration when we do a wound assessment. Classifying wounds, grading by tissue involvement. There is grade 1, grade 2, grade 3, and grade 4. Grade 1 is non-blanchable erythema of the skin, intact skin, where discoloration of the skin, warmth, edema, induration, or hardness may also be used as an indicator in people with dark skin. Grade 2, partial thickness, the skin loss involving the epidermis, the dermis, or both. The ulcer is superficial and presents clinically as an abrasion or a blister. And in grade 3, the full thickness, the skin loss, there is skin loss involving damage or necrosis of the subcutaneous tissue that may extend down but not through underlying fascia. And at grade 4, extensive destruction, there is tissue necrosis or damage to the muscles, bones, or supporting structures with or without full thickness skin loss. Clinical appearance. Describe the type, we can describe the type of material present in the base of the wound. A wound can consist of a slough, which is yellow in color. It could be necrotic tissue, which is black in color. Infected tissue could be green, granulating tissue red, and epithelialization pink. So a slough looks like this. Our aim is to liquefy the slough and to aid its removal. So dead cells accumulated in exudate, prepare wound bed for granulation, assess the wound depth and exudate levels. You can use hydrogels, hydrocolloids, alginates, and hydrofiber dressings. In a necrotic wound, our aim is to debride and remove the eschar, provide the right environment for autolysis, assess the wound depth and exudate level. We can use hydrogels, hydrocolloid dressings in such wounds. Infected wounds, our aim is to reduce the exudate, odor, and promote healing. So the clinical signs of infections need to be seen. Then we need to do a swab wound to check if any type of infection. First, to start with systemic antibiotics, then treat symptomatically the exudate and the odor control. These dressings need to be changed daily. In a granulating wound, our aim is to support granulation, protect the new tissue, keep it moist, assess depth and exudate level. Moist wound surface non-adherent dressings to be used. Treat over granulation, hydrocolloid, foams, and alginates. In an epithelialization wounds, the aim is to provide suitable condition for the resurfacing. You can use film dressings, hydrocolloids. These wounds should be disturbed as less as possible. Try not to disturb these types of wound too much. Wound characteristics consist of exudate, odor, condition of the tissue within the wound, and the condition of the surrounding area. The surrounding skins should be monitored for any eczema, psoriasis, maceration, excoriation due to the exudate or a bowel content in colostomy, self-inflicted damage. Wound monitoring healing process, wound dimensions, wound assessment charts, frequency of assessment, and plan of care is very important in a wound care management. Dressing choice is the uttermost important. What is available? How do we choose? Does the patient have a say? Do we consider the cost? Are choices restricted by a protocol? And how do we evaluate? The ideal dressing is a dressing that creates optimal environment, wound debridement, wound cleansing, and alternative therapies. The purpose of dressing is to aim debridement, to remove the excess exudate, to control the bleeding, to protect a wound, and to support healing. So the dressing choice varies from non-adherent wound contact material, films, hydrogels, hydrofiber dressing, hydrocolloids, foams, alginites, and there are many more choice of dressings. Dressing choice, a hydrocolloid is a pectin gelatin environment for autolysis to debride slub or necrotic wounds, occlusive hypoxic environment to encourage angiogenesis, and waterproof. Different presentations are like, for example, you see ergotol in this picture. Film dressing. Film dressings are semi-permeable primary or secondary dressing, clear polyurethane coated with adhesive, conformable, resistant to shear and tear, do not absorb exudate. For example, are tegaderm or opsite. Dressing choice like foam dressing are advanced polymer technology, non-adherent wound contact layers, highly absorbable, semi-permeable. There are various types and adhesive and non-adhesive. Dressing choice in hydrogels and alginites. Hydrogels are sheets or gel, low exudate, shallow wounds, dehydrates necrotic tissue, secondary dressing needed, may cause skin maceration. And in alginites are seaweeds dressing, foam or gel over the wound. They are easily removed. Moderate to high exudate wound can cause pain and help to debride a wound. Different presentations. Debridement methods. For a debridement, you can use hydrogels, hydrocolloids, alginates, hydrofiber dressing, surgical, wet to dry dressing, and ripple. Tissue viability. Documenting wound care. Potential for litigation. Good staff communication is important in a wound care management. Continuity of care to access the process, progress or deterioration. Should be factual and not subjective. Wound assessment charts are important. Conclusion. Wound care is becoming more complex as the range of wound increases. Correction of the underlying causative factor is essential. Key principles must be to adhere with regards to the basic patient and wound assessment. Thank you.